And take it away.
All right, very good. Well, my name is Stefan Hartmann here. I'm a PA, and I'll be co-presenting tonight with Dr. KAthleen Ruddy, who's here in the chat with us too. KAthleen, can you give a brief introduction to yourself? Because this is one of the first meetings you've been at, right?
This is the first. Can you hear me?
Yes.
Okay, great. So I'm a cancer surgeon. I've been in practice for 30 years. I was winding down my practice when COVID broke out and had to do a course correction. I began taking care of patients, my patients with COVID and patients with COVID, persuaded by what I thought were compelling data with regard to the efficacy of ivermectin in the treatment of SARS-CoV-2 infection. I had some experience indirectly with the first SARS outbreak, and I knew that it wasn't possible to make a vaccine against a SARS virus. So I was very skeptical of the story that we were being told about the nature of the outbreak. The epidemiology did not make sense to me. The push for vaccines seemed homicidal and suicidal, and ivermectin looked like it worked. So I began treating my patients, cancer patients, with ivermectin. And then I began treating patients with ivermectin because people started to find me. I wrote medical exemptions against the vaccines. And I wound down my surgical oncologic practice and became a freedom fighter. And when I looked at the world's literature on ivermectin, which is sort of something that I would just tend to do, I discovered like 20 years worth of research, laboratory research, on the potential of ivermectin to improve the survival of patients with cancer. And I was like, what? I thought I was very well trained, and this is the first I heard of it. So the more I looked at it, the more I was intrigued by this, studied the mechanism of action, and was introduced to a patient post-vax, 2 mRNA vaccines, and then 2 months after his second shot, a young man, 53 years old, developed stage 4 prostate cancer. And he went through the whole entire treatment protocol, following the rules, to a T. But then he was stage 4, and he had cancer in 4 different, places in his body. And it was just a disaster. The doctor said, there's nothing more we can do. And so I began to just sort of encourage him, giving him sort of compassionate care. He lives in Illinois. I'm in New Jersey. And about 2 months into this, I said, I don't know whether this is going to help you or not, but I have seen some literature to suggest that ivermectin would be beneficial against prostate cancer cell lines. If you want to give it a try, I'm happy to sort of give you some guidance. He started it. 2 months later, he's in complete remission. He's remained in complete remission for 9 months. He's feeling tremendously better, and so on and so forth. And so that was like my dive down the wormhole. So one thing led to another, and Stefan and I found each other recently in one of, I guess, a Signal chat or whatever. I'm on a million of these platforms now. And he and I began to talk about the efficacy of ivermectin. And I now have 12 patients that I have been following who've been using it. 3 in complete remission, 1 making remarkable progress, everyone else doing better and improving. So I'm here tonight based on Stefan's invitation for me to come and join the conversation. I'm glad to be here. Thank you.
Yeah, it's quite exciting. And so this presentation is actually part 2 of my series on this subject. I gave this presentation a couple months ago to this society regarding my involvement in the prostate community trial, which is largely based in the Philippines, and we use the Viber platform to communicate cases. There's a Google Drive as well where we try to assimilate these cases, and I'm going to go through a couple of those. But this is going to be a lot with what I've been doing as well, and my kind of what I've learned along the way. And I want to start out with this one case because it's emblematic of the type of patient that is interested in doing this sort of study and what you'd have to deal with if you want to actually run a study. So this is Teresa. She was found to be chronically anemic, had a lot of GI endoscopies on both ends. They didn't find it until they did a capsule endoscopy. Lo and behold, small bowel tumor. So they started her with conventional therapies, which was resection and chemotherapy, but she's very holistically minded, and she did a lot of research, and I'm her primary, and she asked me if there's anything else she can be doing complementary to this. And boy, is there a lot you can do complementary to this. So one of the things in the literature that you'll find is doing fasting with chemotherapy. The fasting with the chemotherapy, it helps, one, potentiate the chemotherapy, but it also protects the cells. And that's exactly what we did. Every time she did the chemotherapy treatment, she would put herself into autophagy with the Prolon fast, the L-Nutra Prolon fast, which is a 5-day fast. It's very simple to follow. And she had very good results with this. She didn't actually lose any hair. She didn't have a lot of problems that some of the patients have. Although FOLFOX is a very mild chemotherapy if you compare all the chemotherapies out there. The other thing we did is we put her on low-dose naltrexone for the same mechanisms where it does potentially protect the good cells, your own cells, from the harmful effect of chemo, and potentially can potentiate the effects of chemo to target the malignant cells. And so we use this as well. Then we also used ivermectin, and Dr. Ruddy can go into more why we use ivermectin in this. And there's a lot of studies on this, but it can induce cancer cell death and help with breast tumors, all sorts of tumors. We started, and why LDN, there's a little bit more on LDN, but I have a whole lecture on LDN, but we're not going to go too deep into it. The mechanism for why it works is a little bit mysterious, has to do with opioid receptors in the brain. This patient also used fenbendazole. So as another kind of variable in this, I mean, Dr. Ruddy have talked about this before, and how it potentially can cause some liver injuries, but this patient went along with this anyway, after understanding it. It's actually not a prescribable medicine. She went and bought this on her own from a source that was pretty good. But fenbendazole has anti-cancer therapies as well, so she threw that into the box as well. So she did the chemo, did very well on that. But then not only was she doing all these pharmaceuticals, but she was doing a lot of herbs, things I never heard about before, Garcinia, Cambogia, right? She's throwing the kitchen sink at this thing. So there's a lot of variables here. And she did the conventional, got the surgery, had the bowel resected. They did the PET scans, they did the CAT scans, and what they found, one thing that we monitored throughout this protocol was these nodules, which we'll see here in the middle here. She had a nodule in the right middle lobe, which was 8.1 centimeters. It shrunk over this protocol to 6.6 centimeters, so there's a decent improvement there. And she had the abdominal tumor resected, a bunch of lymph nodes were taken out, 2 were malignant. She added on a bit of the lactoferrin, which was part of the prostate community trial protocol. So she had lactoferrin in there in the form of raw milk, actually. I followed up with her today because she finally got the CAT scan results back, and there was no more nodules in her lungs. They're undetectable, other than something maybe in the left lung now, a very small 6 millimeter nodule in the left lung, but the 6 centimeter mass is gone in the other side. But yeah, the point of this one is that when you do a trial like this and you enroll patients that are interested in ivermectin therapy, you're going to get someone who's going to be doing a lot of other things as well. We're going to get into some prostate, because that's been my biggest involvement in this trial, is just looking at for benign prostatic hypertrophy. And some of the patients I've enrolled, they've had vasectomies in the past, and there is, if you look at some epidemiological data, there is an increased risk for prostate cancer for men that get vasectomies. So that's just something I want to start out with. So this is a patient I presented in the last conference here, this older gentleman. He is a great study subject because he's kept very good track of his prostate scores since December of 2014. And the reason he was interested in this is because in his tracking of this, he noticed that ivermectin dropped his PSA levels. This was back in 21 when he was getting ivermectin, I think from India or so forth, and his prostate levels dropped. And so he actually talked to me about this, and I was like, well, let's do it again, because he was still having some problems with his urination issues. He would urinate more in the night. He also was a hypertensive too. The most interesting thing about his case is that when we gave him the ivermectin and lactoferrin, his blood pressure dropped, right? He's a hypertensive. He sits a diastolic of a 90. His blood pressure went so low, we had to get him off hydrochlorothiazide and losartan. The other interesting thing is that when he stopped the lactoferrin, because he did stop it because he got side effects, he got the vision floaters, even at what I thought was a lower dose for him, which was about 0.4 milligrams per kilogram. But he got the vision floaters. We had to drop it down to 20 milligrams. And that helped his urination, his nighttime urination symptoms. However, I followed up with him recently, and he stopped using the ivermectin and lactoferrin. The nighttime urination symptoms, they came back. His blood pressure's come up again. He has to get back on hydrochlorothiazide and losartan again. So when I looked at a therapy in integrative medicine, I look at a curative therapy or a therapy that can really improve quality of life. So this is kind of like, at least in this patient's case, this is a regular therapeutic. It seemed to help with symptoms, but it didn't cure it. Maybe we didn't do it long enough. Maybe we needed to try something in addition. This is another patient we tried this on. He has myelodysplastic syndrome. He's very low hemoglobin all the time. He had very mild prostate symptoms. He was interested in this potentially because it could maybe help with myelodysplastic syndrome. So we did the lactoferrin and ivermectin, and he did it for a solid like 2 months. He really tried. And what we found is that it does not work for his myelodysplastic syndrome. He was still anemic. And so we approached it from a different mechanism. We started, in addition to him getting the Procrit, because he was still low just on Procrit, increasing organ meats like bison spleen to increase his iron concentrations. And I started him on testosterone. And the testosterone is probably the biggest difference for him. I mean, he felt really good, better than he had in years. The other interesting note is, again, these patients, we're doing a lot of different things with them, not just one. But thankfully he did separate the methylene blue protocol away from the ivermectin, again, to see if it would help with various things. It didn't seem to help him much, but it did improve his wife's dementia significantly, at least for them. I mean, I wouldn't consider that too much of a significant response, but I guess if you're living with someone with dementia, any sort of improvement, you would notice it. They noticed with methylene blue, she was more responsive. She didn't sleep so much. So that's something that Dr. Halas has been talking about, how methylene blue can be a cognitive enhancer. So this is a patient, a female, 56. She'd been having chronic ice pick headaches for years, prescribed her ivermectin for COVID, and she realized that her ice pick headaches went away. And now she takes ivermectin prophylactically at 12 milligrams, and it prevents her ice pick headaches where nothing else had really helped. And she had been seeing neurologists and so forth, and nothing really had improved this. Here's another prostate community trial case. We have this patient, David. He's a 62-year-old diabetic. He's been on Flomax and Viagra. When I do these trials and I start them on ivermectin, lactoferrin, if it's going to work for their prostate symptoms, it's going to work within the first week, or sometimes within the first night even. And that's what I see repeatedly in many of these cases. So he described to me that his stream was almost completely normal after the second dose of ivermectin and lactoferrin, and he woke up with morning wood. And this is another thing we've seen in the prostate trial, is their erections are stronger in the morning, or they weren't having erections at all for years, and suddenly they're getting erections again. And the mechanism behind this is not entirely clear to us. But unfortunately, this patient had to stop ivermectin because he got a bit of vision floaters. But interestingly enough, the one thing that did seem to stick with him after doing this protocol was his hemochromatosis resolved. He had had hemochromatosis and would have to donate his red blood cells to the red bloods pretty regularly, like every month for 20 years. And suddenly he went into the red bloods and they said, you can't donate. Your hemoglobin is low. And he thought there was an error. We repeated his blood. We did the blood work to confirm it. And sure enough, he had a low hemoglobin. He's doing well here. Not quite clear why his hemochromatosis resolved. Quite bizarre, really. Potentially has to do with lactoferrin. Lactoferrin, it works on iron-loving bacteria that eat iron. Lactoferrin actually steals iron away from these pathogens, and it can act as a natural antimicrobial for this purpose. So not quite clear why it might be working for hemochromatosis. This is the first incidence I'd ever seen of this, and I hadn't really seen it again. This is an elderly Austrian doctor. He came to me through the group chat network. He was in a bad shape when he came to me. Pathological fractures, extreme pain on hormone blockers, you know, the conventional therapies, painkillers, morphines, ibuprofen. So we somehow got him ivermectin and lactoferrin. I'm not quite clear how we got it because Austrian authorities come down pretty hard on it. And we did it for a while, and he didn't have much improvement in his pain. So this case, he passed away shortly after getting spine surgery in a last-ditch effort to improve his chronic pain. But the conventional therapy did not work for him. This patient here, he came to me, chronic prostate issues, having had prior laser ablation of his prostate. He notably, he drinks a decent amount of alcohol every week, 4 to 7 glasses per week, a couple of cocktails. Prostate size was 4.3 by 5 by 4.4, had a laser ablation in 2019. So what do we do for this guy? We ran some labs to kind of see that there's some metabolic syndrome going on, really high lipid particles, insulin resistance. CBC looked okay. A little bit of actually poor health of his blood cells, actually. Glucose high, so diabetic. Hemoglobin A1C, diabetic range in my book. Let's see, vitamin D was okay. Testosterone, very low, hypogonadal, low dihydrotestosterone. So interesting, the conventional thinking is high DHT causes prostate enlargement and growth. I have not seen this to be the case. Oftentimes I'll have patients with low DHT levels and they still have large prostates. I think the large prostate has more to do with metabolic syndrome than anything else. Inflammation and metabolic syndrome drive this disease. So here's some other testing we did. B12 very low, insulin very high, 12. I like to see insulin below 5 ideally. C-reactive protein high as well. So a lot of inflammation going on. GGT also high, a proxy marker of glutathione, high oxidative stress going on in this guy. So we put him on a couple supplements, again, multi-drug therapy, N-acetylcysteine, B12. Wanted to get him on testosterone too, but we'll find out he actually didn't take that. Now, he was interested in this trial because this guy, he works with prize animals. He works with dogs. He trains them. And for years, for 20 years, he's fed these dogs ivermectin and fenbendazole. Why? Because you deworm the animals. And when I described, hey, I'm involved in this trial, we're using these antiparasiticals to treat prostate cancer, he was all on board with this because he would never feed his dogs anything that was harmful. So he was on board with trying these things. So that's exactly what we did. And what he described within, again, the first week is that his prostate symptoms resolved, is that he's no longer getting up at night to pee. We actually did this, interestingly, in like a full moon protocol where you kind of cycle these things around the full moon. There's some suggestion that you can hit different parasites at different cycles of the moon. So we just did that kind of as like a fun thing to do. And it seemed to work, at least to temporarily treat his prostate symptoms. Unfortunately, again, this seemed temporary, the benefit of his prostate symptoms. After he stopped the ivermectin, the problem seemed to come back. So maybe we need to do a longer course, as we may understand from some other cases here. But he hasn't made some other changes, so we're still waiting on him to use some testosterone, do some B vitamins, start doing some exercise. He is reducing the alcohol, which all of those things will massively improve his inflammation, his metabolic disease, which I think also has a profound effect on prostate. This is another patient who was involved in the trial here, and he wanted to do the ivermectin. He actually suggested it to me for his prostate symptoms based off his own research. So he had difficulty urinating 1 to 2 times a night. He was up trying to pee, a little bit of hesitation with the pee. And he had that for years. We ran the ivermectin, and this guy's still on it as far as I know. Last time I checked with him like a couple weeks ago, he's still on it, like month 3 or 4 now. His prostate specific antigen has dropped from 19 to 12 over this time. He's using lactoferrin 500, ivermectin 21 dailies. And when he's using it, and he's using it every day, he no longer has to wake up to pee. So this is a guy, we haven't actually cycled off it to see if there's a lasting effect. But when he's on it, his symptoms of benign prostatic hypertrophy are non-existent, and his PSA is improving. Now, mind you, he's also massively improving his metabolic health. This guy, he's training every week. He's actually doing testosterone therapy, mind you, right? Testosterone isn't increasing his PSA. His PSA is going lower. And so there's a very positive case here. Lifting, testosterone, doing ivermectin, doing all the right things. This is a case from the Philippines side of the trial. In the Philippines, you'll see some more extreme cases of cancers. So this lady, she had a full hysterectomy and a bilateral oophorectomy, and surgical pathology showed tumor cell invasion. So they starting the chemotherapy with this patient, doing some other supportive therapies. 750 milligrams of lactoferrin without ivermectin. So this is a case where they didn't do ivermectin for one reason or another. It's not clear why. The interesting part about this case is that the blood work improved. So her blood work, her hemoglobin and her white blood cell count improved. The hemoglobin normalized. Her, again, ultrasound was clear, but obviously there was conventional therapeutics involved, chemotherapy. So maybe that had a more powerful role than just lactoferrin. But I think lactoferrin has a pretty important role in hemoglobin, specifically the red blood cells, and seems to have an intelligent effect on them, whether it's decreasing them if they're too high or increasing them if they're too low. This is a 61-year-old female with breast cancer. This is actually a physician that I met in the group chat, and the group chat was helping her figure out what to do. She was doing high-dose ivermectin with lactoferrin, but she did not like it because she felt depressed on these agents, so she stopped them. She then started fenbendazole, the 300 milligrams twice daily, which in my opinion is quite a low dose. And she felt confused, unable to do simple math. And so she stopped that as well and started B1. Supposedly, through her research, she thought that it was a thiamine deficiency, potentially because fenbendazole can deplete thiamine. Maybe. This is some of the results that she's had with this therapy. So there has been some improvement in the tumor. So that's a positive result there. So she was quite happy about that. So that's the kind of as far as I've gotten in my research on this. Kathleen, maybe you'd like to give some of your studies here or discussion here. Pharmacology, if you want to go into some of that.
Right. So I'm not sure how I advance the slide, so I'll just say advance the slide. Or
Yeah,
next.
let me know.
Okay, great. So these are the documented mechanisms of action that appear to help explain some of the benefits that the scientists are seeing in laboratory studies, in cell lines, and in animal studies, in terms of its ability to interrupt malignant growth at various stages of malignancy. So, 1, 2, 3, 4, 5, 6, 7, 8, 9. It's bewildering that that this one drug could do all of this, but there is a simple analogy that I think helps to frame our understanding of the potential of ivermectin. That is to say, it appears to work in many ways in the same fashion as it does when it kills parasites. So if you envision a malignantly transformed cell as a parasite, which really it is, as it turns out, then you begin to examine what are the mechanisms by which ivermectin kills these cells. So it throws them into apoptosis, programmed cell death. It prevents the cancer cell from guarding against programmed cell death. So one of the things that cancer cells do is they know how to basically flip the switch so that the cell, the immune system, and the internal surveillance inside the cell that normally is on the lookout for trouble, and if it sees trouble, just burns the place down. Cancer cells know how to interrupt that internal and external defense mechanism. So ivermectin is an end run around that. It induces immunogenic cell death, which really means that when the cell is transformed, the immune system recognizes it as, oh, who the hell are you? What are you doing here? You're a bad actor, and then attacks it. So the cancer cell has evolved so that it can defend itself. It hides itself from the immune system. It inhibits the abnormal proliferation of cancer cells. So one of the things cancer cells do, obviously, is grow rapidly and clone themselves out in all directions. The WNT Wnt signaling is a key identifier in cancer cells. It plays a role in cancer progression, malignant transformation, increased aggressiveness, and ivermectin nails that. It inhibits the formation of cancer stem cells. And this is really important because, cytotoxic chemotherapy only works for cells that are dividing, in the state of dividing, which is why you have to keep giving it, over a period of time, in the hopes that you're going to get increasing kill off of the rapidly growing cells. And it's very hard to get at cancer stem cells because they're not proliferating, they're not dividing, they're just sitting there, like the militia waiting to attack again. And ivermectin limits their ability to do that. Very interesting, it restores tamoxifen sensitivity to triple negative breast cancer cell lines. That's very important because then that would render a patient who is triple negative breast cancer, about 15 to 20% of breast cancer patients are triple negative. It would restore them to tamoxifen and aromatase inhibitor sensitivity. It inhibits angiogenesis. This is absolutely necessary for the growth of cancer cells. You can get a cancer cell that has formed and it can divide and form a little mass, and so, but it's not going anywhere unless it gets a blood supply. It needs it needs that currency to get going, and ivermectin inhibits angiogenesis. It inhibits the tubulin function, which is the architecture, the structures that the cells need in order to create a scaffolding upon which the cell then divides. And that is one of the ways that it gets at parasites, one of the very well-known ways it gets at parasites. And it looks like it's synergistic with the standard chemotherapy. This has been shown in multiple animal studies, melanoma, breast cancer, and so forth. So all of these things, ivermectin, we know this is what it does. Scientists, 20 years worth of research, can put this on the table as known mechanisms of action. And now we can begin to see, well, is there any correlation to clinical benefit, knowing that this is the potential? Next slide. Dosing, okay?
Yes.
Who the hell knows about dosing? Let's just say right here, right now, that I don't know what the appropriate dose of ivermectin is in a patient with cancer, and that nobody does. We just have not done the proper studies. We need studies. Well, we'll get to that. This is my main argument, is that we need proper studies. And I've actually launched one, I think. But right now, it's an educated, experienced, rational wager that what you're giving the patient in terms of dose of ivermectin is appropriate. There's kind of an urban myth out there now that, oh, you know, higher doses of ivermectin are warranted in cases of cancer. I don't see that. In my very brief anecdotal experience, I've not scaled up the dosing at all. The third bullet here is a statement based on a very good paper published in 2018 showing that 18 milligrams per day for an adult is as good as body weight dosing or 36 milligrams of ivermectin a day. So as of my reading of this paper a few weeks ago, 18 milligrams is what the patients will be getting. It has a very wide therapeutic range, so you can use your judgment. You know, if you think, well, I happen to think, you know, I've read papers, so this is my professional opinion, I'm gonna scale higher. You can scale to the moon. Okay, it's hard to hurt a patient with ivermectin, and furthermore, in those instances where patients have clearly been harmed by sky high doses, they recover. You just stop giving it to them, and they recover in about 3 days. Now, here is an important note, because patients with cancer have cells with metastatic potential by definition, and cells that can metastasize can go anywhere they want. Now, typically, certain cell lines like to go to the liver, the bone, the peritoneum, and some like to go to the brain. So, you know, lung cancer gets on the interstate and goes right to the brain. And then there are patients with brain tumors. So ivermectin, by and large, does not cross the blood-brain barrier. You've got to take that into consideration when you're thinking about prescribing ivermectin for a patient with cancer. If the patient has a brain tumor and there's no compromise of the blood-brain barrier, then giving them ivermectin is probably not going to be effective. Hypothetically, but probably not going to be effective. On the other hand, if the patient has a brain tumor and has had whole brain radiation, that patient has an alteration of the blood-brain barrier, in which case ivermectin can get into the CNS, but that could be a problem. That causes CNS depression. And in collies, it kills the animals. Bendazole will cross the blood-brain barrier in humans without producing CNS toxicity. And so, although I am not currently creating a study to look at the question of primary brain tumor or brain mets, plus minus ivermectin, plus minus bendazole, that's probably going to be my next study, because tumors like to go to the brain. And so we can't put off asking that question very long. I think it probably needs to be asked pretty quickly. Next slide.
Well, one question: how would you how would you explain the ocular disturbances I've been seeing so often when I do higher doses of ivermectin? I always thought that was actually a sign of neurotoxicity.
Well, it could be, but I don't know whether we are able at this point. There's another question that comes up that you want to put on the table and answer, yes or no, and that is whether or not there's some inflammation of the eye and the ocular nerve outside of the cranium. That's a possibility.
You know, Stefan, Dr. Harsfield and Lewis would probably know that answer or tap into someone who does.
Yeah, I like your dosing of 18 milligrams. I've never seen it cause ocular side effects at 18 milligrams.
Yep. Okay, next slide.
Yeah.
Okay, so before I got to the epiphany that the world needed a study, and then accepting the divine appointment to do the study, once my 53-year-old male in Illinois with stage 4 prostate cancer had such a good response, I was like, well, what is the likelihood that this patient would have a spontaneous remission of all of his cancer? Well, it's not 0, but it approaches 0. So I thought, okay, big question mark, but ivermectin until proven otherwise. Very soon thereafter, 69-year-old woman with about a 7-centimeter pelvic mass. She randomized herself to doing nothing, but sort of juicing and so on. Wouldn't even have a biopsy. Then about 7 months later, I got a call, December 23rd, in the middle of the night. She's getting ready to blow out her bowel. So she got worked up. She had an 18-centimeter tumor in her pelvis, a Krukenberg tumor. And she was admitted to UVA, and she was tuned up and given TPN, the whole works. And the surgeon was able to resect that tumor. She had liver mets at the time. Got clean margins everywhere. They went in with like 4 different surgical teams. They were there for about 8 hours. She had an uneventful postoperative course, another remarkable report. And then they were all over her. You got to have chemo. You're going to die if you don't have chemo. And she was like, thanks very much. She went back to West Virginia and she started taking ivermectin and refused any other interventions. She did some red light therapy, and she, like one of Stefan's patients, she was taking everything. So God only knows. But I was able to persuade her to at least get an ultrasound, and she was free of disease and has remained what appears to be in complete remission. She has not consented to getting a proper CAT scan, but she's driving around the country and she's eating and she's gaining weight, and her ultrasound of her liver was fine. And this is one of my favorite guys, a 71-year-old Eddie in Florida. Eddie smokes, Eddie drinks, Eddie fishes. He doesn't go to the doctor, okay? And for the past 18 months, he was losing weight and he couldn't swallow and then he couldn't talk. finally he goes to the doctor. They do a biopsy. He's got esophageal cancer. They do CAT scan. He's got 2 esophageal tumors. And they're going to give him this, that, and the other. He goes, no. A friend of his had prostate cancer, taken ivermectin, and apparently had good response. Eddie had a bunch of ivermectin for COVID. So Eddie just started taking ivermectin. God only knows what he was taking. About 2 months later, was able to persuade him to get a follow-up CAT scan. No evidence of tumor anymore. And he was doing well at a 6-month follow-up after that. And he's doing so well that he doesn't answer his telephone now. I know he's doing fine, but he's done with me. He's done with everybody else. He's doing fine. Next slide. And these are, actually, I'm up to more than this. I think I've added 2 or 3 more patients since I made the slide. The first, a 7-year-old boy with a primary Ewing sarcoma of his nasopharynx 2 years ago. And he was just ready to die in February. Just radiation, chemo. The tumor had progressed posteriorly, made a right turn and a left turn in the internal auditory canals, started growing out his left external auditory canal. They were thinking of cutting off his ear. It was a disaster. Feeding tube, hadn't gained weight in 2 years, and so on. His mother was giving him everything, including 4 times the body weight dosing of ivermectin, because the guy down the street said, you should give him a lot. So she and I began to work together and modified this protocol so that he got what would be a standard COVID dose, a body weight dosing. That's what he was on, a body weight dosing. And chaga mushroom tea, which I happen to be a fan of. Increased his nutritional support more appropriately, I thought. And he continued with a new round of chemotherapy, more experimental. And the tumor has regressed entirely. He had a 7th nerve entrapment, so that he looked like he'd had a stroke. He didn't have a full smile. So now he's got a full smile. The tumor has regressed. He was on his little spin bicycle for 45 minutes, lifting weights, swimming out in the backyard, digging for dinosaurs, gaining weight. Just amazing. So, but it's been a real challenge because I get in touch with the mother. She's very faithful, but I find that 6 days that I'm not in touch with her of the week. She goes in there, she does something else. So she was giving them sky high dosing of chlorine dioxide. You know, I really have to keep reeling her in, you know. She's like one of the dogs of war. But the child is doing very, very well now. And I think the plan is going to be that the medical oncologists are going to want to continue to give him chemotherapy until the tumor shrinks. He's got scans in 2 weeks. And if we can get the tumor to resolve completely, the medical oncologists who are not aware that he's getting ivermectin will quite naturally just pull back on the protocol. They'll stop giving him the chemotherapy, and we can continue with the ivermectin, and then we can begin to add other kinds of things. But this was a case in which there was whole brain radiation, compromise of the blood-brain barrier. He was getting sky-high doses of ivermectin, complete CNS depression, pulled back to a normal, more normal ivermectin dose, and he perked right up. And then I've got some breast cancer patients. One of these women had what sounds to me like inflammatory breast cancer. She was not diagnosed with inflammatory, but I think that's what it was actually. So her tumors, you know, grew out of her mastectomy sites and into the axilla and supraclavicular, and she was getting chest wall mets. She started ivermectin, and within about 4 days, one of the chest wall nodules basically disappeared. So I think she's getting a good response. And other patients, one with colon cancer, small bowel, multiple myeloma, another prostate cancer. It's too soon to be able to say much, except that the patients clinically say they're feeling better. No one has gotten worse, but it's too soon. I haven't gotten any real follow-up scans, measurements on them. Next slide. Do I have another slide?
Alpha study.
Okay, so this is the alpha study. So that all being said, I was like, okay, enough for the anecdotal information. And then I got in touch with Stefan and a bunch of other doctors around the world. And everybody's just trying it, you know? It's like the Wild West.
Yeah.
That's great. We need a study. And so I launched the alpha study. I created a PMA. So the patients will come into the PMA. I'm somewhat protected. And then my PMA is part of another PMA. So it's like this nested Russian doll kind of thing. The patients will have stage 3 or stage 4 cancer, and they'll have a consultation with me. Some of them find me. I'm having doctors refer to me. And I will discuss with them, go over their case with them, and answer all the questions about ivermectin. And if at that point the patient wants to continue ivermectin that they got wherever, or they'd like to try the ivermectin, I'll refer them to a physician who can prescribe it. So I will not bias the study by being the prescribing physician. I'm just there to observe and record the data. And it's going to be a 2-year study. The question is, apart from anything else that anybody's doing, if ivermectin improves the survival of patients with cancer, plus minus 16 other things, the curves will separate. That is, we can compare the outcomes of these patients to historical data. Like, for instance, the first patient, what's the likelihood that a guy with stage 4 prostate cancer just goes into complete remission spontaneously? Yeah, it's very low. So begin to see, once these curves separate, and the only thing I'm looking at is ivermectin, then we can make an argument that we've got a prospective observational study with full informed consent, and there appears to be a separation of the curves, at which point you can then argue, now it's time to do a more controlled, more specific, probably series of studies. Look at the dosing, look at the duration, looking, adding this, adding that, the types of tumor, the age of the patient, and so on and so forth into infinity. That's where I am today.
Yeah. That's great. I think that's all we have here. Very good. Well, that was great. Thanks for presenting. Let's see if there's any questions. Can you use animal ivermectin? No, we use prescription ivermectin, Amex Pharmacy. I think, Dr. Reddy, you have a pharmacy as well you work with that can get you real ivermectin. What would you do? Prophylactic daily amount to fight the growth of cancer and parasitic cleansing. Well, prophylactic? Well, if you're gonna do prophylactic dosing, just follow FLCCC guidelines. That's 0.2 milligrams, 0.2 milligrams per kilogram. 0.2, yeah.
I think that would make a very important study, because there are women who are at increased risk for breast cancer. I mean, you can just think about doing a study with the patients who have a BRCA mutation, patients who have atypical ductal hyperplasia. So prophylactic dosing to try and offset the risk, that's a worthy study. That's a long study. Okay, you're talking 5 years, 10-year study. And you'd have to sort of think creatively about what the dosing would be. My hunch would be that you would go at it sort of a daily dose for 6 months and taper to twice a week and then follow after that, because the 6 month ought to, hypothetically, theoretically, sterilize the field. And then you would just do a maintenance dose and follow the patients. And again, we have huge historical data. What is the risk of a woman who has lobular carcinoma in situ? Okay, well, you know, it's 10% per year, whatever, depending on other risk factors, depending on the age. So what if ivermectin could be used to mitigate the risk of known risk factors for various cancers? Colon cancer.
I will keep my patient Teresa on it 12 milligrams twice weekly, and she's on low dose naltrexone as well for neuropathy pain, because the chemo seemed to have caused some neuropathy. So she's going to stay on that too, because it helps. Right,
and but the question is, how long would they need to stay on? So we know patients who have increased risk for breast cancer, pretty high risk, if they take tamoxifen for 5 years, that gives them about 15 years worth of benefit. So these kinds of questions are answerable, and it's rational to pose that kind of question, rather than, okay, just take it indefinitely. Well, maybe you don't need to take it indefinitely. Maybe you just need to take it for 2 years or 3 years, and we see how you do after that. Because you could be returning these abnormal cells, as we saw from the pharmacology, we could be returning them to a baseline normalcy, and then pull back on the ivermectin as not being necessary.
Melvin asked, are you worried about ivermectin interaction with ongoing chemo? I'm not. Are you?
No, haven't had that problem at all. Especially the 7-year-old, you know, he's been whacked and whacked and whacked.
No issue.
Yeah, he has to take his chemo in the hospital now. He stays there before. It's myelosuppressive. It's a big deal. It's a big hit. He gets his ivermectin right along. His mother gives it to him right along, no problem.
Someone noted that, yeah, you're not using lactoferrin in your protocol, Dr. Reddy.
Right, and this is why, because I don't know that much about it. I'm just learning about a bunch of other things. Lactoferrin was new to me. And I tend to be kind of person, if something crosses my radar screen that other people find would be beneficial, I want to understand that it's true and why it's true before I start doing it. So I've just about nailed chlorine dioxide. That took about a month for me to be able to understand how and why that works. And I'm actually quite a fan of it at this point. And then I guess the next homework assignment is for me to get up to speed with lactoferrin. So I will only add these things as I understand that they work and why they work. And the other thing I would caution people, this is just me, this is my view, take it or leave it, but I like to do just one thing at a time until I see how that works in the patient. So for instance, my prostate guy, once I knew that he was fine with ivermectin, and he's been doing the fasting mimicking diet once a month, I'm totally on board with that. I've been doing it myself. I think I've done 11 cycles of MD over the past several years. I just recently added metformin, because I think metformin shows some good benefit in reducing inflammation and reducing risk for cancer and so on and so forth. If the scans come back and they're very, very good, I expect that they will be in September, I will probably begin to add the chlorine dioxide a little bit, not a lot, a little bit, one thing at a time. So my next homework assignment is to understand about lactoferrin. When I do, I'll know when to add it.
Okay, yeah, I'll send you the files on that.
Great, thank you.
Yes, all right.
So what's the goal of this? What's the goal of treatment? Is it the goal is to find out whether those drugs are working or not, or the goal is to treat the patients? Because that will be different, you know. What is the goal here?
Yeah, okay, so the objective of the study is to answer the question, does ivermectin improve the survival of patients with cancer? Now, the patients will decide, and I believe the patients should decide. And the FDA has confirmed this, that physicians can prescribe ivermectin based on their judgment. So if the patients want to take ivermectin, my view is that they should have the option to do so. So I will tell them all about it, what we understand, what the rationale is. And if they make that decision and they're willing to enroll in the study, I'm merely going to follow them with that one endpoint in mind. Does it improve the survival? That's huge. If we can get data to show that ivermectin improves the survival of patients with advanced cancer, that moves the needle on everything else, I think. Not that we won't be attacked.
But if you have, yeah, but here's the point. If you have already a cocktail of adjuvant treatment that will definitely help to cancer patients, and versus just trying one therapy, which is ivermectin as an adjuvant, along with whatever the patient is taking from the oncologist. I mean, there's many other things that would help cancer, and metformin, as you said. So really the study will be difficult because most of the doctors with conscious, and they have a cocktail of protocols that will navigate the cancer, not just ivermectin, but they can add McCarran Blvd, they can add thymosin alpha, they can add interferon gamma, they can add McCarran Blvd, they can add antibodies, which is those antibody that what we call immunotherapy, right. The PD-L1, anti-PD-L1, anti-CTL4. They can also load those into platelet nanoparticle. They can add losartan as antifibrotic. So there's many other things that will definitely help the cancer. And if those doctors with conscious, definitely they will be, the goal is to treat the patient and trying to, in a state of just finding out if ivermectin works. I think ivermectin will work because it's it has just antifibrotic effect of the ivermectin, you know, itself. It's a good thing, you know, because, you know, those blood vessels of the cancer, they get constricted with the fibrosis, and the lymphocytes, they cannot infiltrate there. Just by opening up the fibrosis itself, it's a goal. So I don't know if the doctors here, if they have that access to the treatment of cancer, I think it's better if we can come up with a complete cocktail, and start finding out if this will help to increase the survival. It's difficult to just say, you know, the whole purpose here, just find out ivermectin, and regardless of the patient's, although you have a lot of other things that you can do.
That the patient, patients are not, and the physicians who refer to me, the patients are not excluded from the study if they're taking other things. So I have patients who are taking many other things. If ivermectin, this is my hypothesis, if ivermectin in and of itself will improve the survival of patients with cancer, it will do so plus minus anything else. This was the exact issue that faced Sidney Farber at Mass General back in the 1950s, when he said, you know, this particular cytotoxic agent will improve the survival of children with leukemia. And James Holland came along and said, 3 drugs are going to work better than one. And he explained why. You're absolutely right. There's no reason to think that multi-drug therapy, as it were, is not going to be more beneficial. It's just that ivermectin has been under attack for so long. It's been under siege for so long, and it looks to be so promising. I don't intend to elbow out anything else or any other physician's judgment. I just want to be able to plant a flag on ivermectin so that we can move the ball farther downfield with regard to everything else. If you happen to know, based on your experience, that these 3 things or these 5 things will work, well, then by all means, go for it. I have no argument with that.
Sounds like a plan. And so practical steps for starting this is your PMA, and you got in with the body, right? Your PMA is under the body as well?
Well, what I did was I created my own PMA.
Yeah.
And then my PMA became a member of the body PMA. So
Really?
patients can come, so the patients can come to me. And I'm in the cone of silence there. But then just for added protection, I put my PMA. The patients don't have to then become part of the body, but my PMA is now part of the body, because that's an option with Avery's organization.
Good. Well, how do we practically start enrolling patients in this, and what is your next steps?
Well, you can just tell them there's a doctor who's enrolling patients in a 2-year study to assess whether or not ivermectin improves the survival of patients with cancer. Give them my contact information. I'll have a consultation with them. And if at the end of that consultation, they want to continue, they're willing to participate. And a lot of them, I found more often than not, about 80% of them are willing to participate because they know they need this kind of help. They need someone who can help them understand what's going on with their cancer and how to tease out an appropriate methodology for not only the ivermectin, but for anything else that they might be using.
Yeah. And how would you track all this data?
Yeah. So I'm an old-fashioned kind of girl. I'm doing this hard copy right now for 2 reasons. First of all, because I grew up hard copy, and I can move through hard copy faster than anybody can move through a computer. Really, it's just astonishing. And you know this. If you had some hard copy experience in your life and then you started doing EMR, you're like, oh my God, this is
Not
twice.
me. It's always been EMR for me.
Okay, so then you don't understand. Okay. Anyway, I'm hard copy. But the other thing about hard copy for me is that I'm not collecting volumes of data. Okay. And it's not hackable. Okay.
Yeah.
The system can't crash. No one can steal it. There's no problem with HIPAA. That's it. It's safe. It's in my house. It's a hard copy. It's safe.
Yeah, that's true. And how many patients do you want to enroll in this?
As many as I can get. It's hard to be able to put a number, but what I would say is that Memorial Sloan Kettering published a remarkable study on 14 patients that had 100% response to a monoclonal antibody. 14, front page of the New York Times, 6-month study.
Yeah. So
I figured, okay, I might like to have hundreds of patients, but if I can get a small number of patients and track a preponderance of benefit, and the reason I select stage 3 unresectable and stage 4 is because those curves will separate quickly. Those people are going to die. And if they live beyond their 6-month expected life expectancy, that's a win and reportable.
So you're actually looking for diagnoses where they say you have less than 6 months to live, and that's the type of patients we should enroll, or who should we be looking for to enroll in this particular study?
Stage 3 unresectable and stage 4. Now, those patients will have variable life expectancies, but by and large, their life expectancy is short. A stage 3 unresectable is not likely in traditional therapy to go into complete remission based on chemoradiation therapy.
See.
Patients with stage 4 are usually palliative.
Yeah.
Very few patients with stage 4 get rolled back into full remission. So their life expectancy is relatively short, which means that if there is a survival benefit based on ivermectin, we'll see it without having to wait 15 years.
How are you going to advocate?
Especially if they are a brain-free tumor. I mean, those ones are, I think it's better candidate to judge, because if they have tumor in the brain, ivermectin does not access the brain, unless, you know, there's a problem with the barrier, but it's neurotoxic for the brain. So I think those are the cases.
Yeah. Well, the other thing is that there's some data to show that there's synergy between ivermectin and cytotoxic chemotherapy. So again, there are more questions than answers. There are more questions and you know, there's so many wonderful questions to ask and such a rich opportunity to ask those questions. We should be very excited to have this opportunity. We're like astronauts. Ivermectin and cancer, we're like astronauts. Great. You know, use your judgment, go where you want to go, do what you think is right, and turn this into a multi-center study, as it were. Not a formal multi-center study, but, you know, Stefan's using it a lot with benign prostatic hypertrophy. What a great topic to investigate. That's not nothing. How many men have BPH?
Yeah.
Like everybody over 60? I don't know. It's a lot.
Yeah.
It's a lot of people. So that's not a nothing investigation. So there's a lot to do.
And you have the ability to launch a trial and publish it in a real journal?
Well, it's not a trial because a trial would be comparative. So this is a study like the Framingham study, where you're just enrolling a group of people and you're just observing what happens to them.
Yeah.
So the Framingham study was everybody in the Framingham study lived in Framingham, Massachusetts. Everyone in the Alpha study has stage 3 unresectable or stage 4 cancer and is taking ivermectin. That's the study. Just follow them and see what happens.
Yeah.
At some point, hopefully, once we get answers from the Alpha study, we'll be able to actually do a trial where now we're comparing the addition of X, Y, and Z to ivermectin, dosing ivermectin.
The next question is, how do you find these patients? I mean, this network of doctors, yes, but we oftentimes have pretty healthy patients because they come to us for anti-aging. Where are you going to find these really sick ones with the stage 3, 4?
They're coming to me.
Yeah.
It's word of mouth.
Yeah, it is.
It is word of mouth. I mean, 1 or 2 doctors will hear about me. So I have a doctor in Iowa, and I don't know where she heard of me. I forget where. She sent me 3 patients. 1 in Florida. She sent me 2 or 3. The brain tumor person, the guy who coaches their other children, is telling everybody in that part of the woods. So I'm getting patients there, friends, family, colleagues.
Yeah. We can send you ones from the internet.
I think the best way of getting patients is that, you know, everybody has a specialist, and those specialists, most of the time, because you're a pain management or you're cardiologist, you cannot cross to other specialty because it's the other specialties, they will be harassing you and suing the board. But if you promote yourself as you are improving the quality of life of patient with cancer through integrative and wellness and things like that, so you're not claiming or coming up that you are curing cancer, but you're just improving the quality of life by nutrition and support. That is legally for any specialist, especially if they are working with this new field. It's called chronic disease prevention management, that's being entertained by the American Medical Association, and they did include in chronic disease prevention and management cancer management.
Mhm.
So under that title, if you call yourself as a chronic disease prevention management specialist,
Mhm.
under that title of what's being recognized by AMA, it include cancer. Of course, it include all chronic disease across all medical specialties, which especially we call them multisystemic diseases. And cancer is one of the multisystemic diseases because it affects all systems of the body. As long as you come up with that kind of attitude, I think the oncologist will be okay with you, especially if you hire a nutritionist with you there. That will take all the kind of the jealousy and all this crazy surrounding specialists who are a little bit short in their patience, and they just like to sue other doctors, because most of the problem happens not from the regulatories, it's the doctors suing other doctors. So there is some bad apples among us, and that's actually causing the whole problems with doctors, and not patients. It's real the doctors themselves. It's our fighting each other. But I think with that kind of attitude and presentation, I think it's safe for you to attract patient with cancers in all different stages.
Quite possibly. What do you believe to be the source of the irritation that would have one doctor sue another, and for what? What is the harm? What is the perceived harm?
Well, the harm is that if you are, for example, when I was doing pain management in Delaware, we try not just to mask the pain with lidocaine and give them narcotics. We're trying to get also the root cause. And when you get to the root cause, that's mean you're gonna dig in other specialists. If they are rheumatologist or rheumatological diseases, you're trying to balance the immune system. You're trying to fix the metabolites. If they are cardiovascular, you're trying to restore the oxidative stress and all that, and the lipid and the glucose and all that. So your family physician next to you will get upset because you're managing patients that they're supposed to be taken care of by a family physician or supposed to be taken by cardiologist. Right. And then those patients, they see that you are providing better health, a better quality of life, then you just draw all those patients to you, and those doctors, they get a little bit irritated from that and say, hey, he's treating other kind, it's not under a specialist and all that stuff, and they start suing. That's actually what real happened. But if you come up and say, as a nutritionist on the side, and you hire a nutritionist on the side, and you say, no, we're just trying to improve the quality of life by lifestyle and some things, just to improve them. We're not curing or, I think that's and especially if you use a title that's being recognized by American Medical Association, which is Chronic Disease Prevention Management. And the reason why they came up with this title, because when COVID hit, all those specialists, they fail. Why? Because it's a multisystemic disease, COVID disease. It's not one way. And you have to manage everything in order to tackle this condition. And that's why they feel there's a gap, and they came up with chronic disease prevention management. The beauty of this, if you go to the AMA, under that specialist or under this field, you can manage cancer. So if you come up and say, I'm doing chronic disease prevention management according to American Medical Association, and especially if we unite together and we work together under this field and come up with residency and fellowship and all that, and entertain this field and expand it, I think we can be more safe to come out and treat or manage those patients better than oncologists, because oncologists, they're following the big pharma, and they cannot go out of the big pharma because they want to sell their chemotherapy and the radiotherapy in the mainstream. They don't want you to be doing other than things. You want to spend all the money in those things. And most of the oncologists are really under the control of the big pharma. Their protocol and regimen, it's all extracted from what the CEO of the big pharma is telling them to do, or a doctor who's been loyal to those people. But you can break through that by labeling yourself with CDPM and put yourself, kind of, it's more conservative or it's more protective than, because all this integrative regenerative holistic wellness, they're being red flagged by by the FDA. And the mainstream medicine doctors who are they actually fueling this things where we look like wackos and snake oil providers and things like that. But if you line yourself under something that's being recognized by AMA, then all those FDA and all that stuff, they come to me, hey, AMA is entertaining CDPM, and that's what we're doing. We're not doing integrative or stem cells or anything like that. We're doing just managing straight chronic disease and prevention according to the AMA. And I think that's the best way to provide kind of a shield against this harassment and psychology of the system.
Does the AMA post any guidelines or credentialing that limit the people who can actually use that as a designation?
They actually are promoting for doctors to start putting curriculum, fellowship, residency. Yes, they're entertaining it strongly. If you go and you write down AMA space CDPM, literally like this, you will see titles, and you can see the things that you're doing as integrative, as regenerative. It's being lined out there. It's about lifestyle. It's about taking a comprehensive history, because they come up with a program. It's called the 360 program, which is taking comprehensive history and comprehensive exam to include all the systems, and so you can reach the diagnosis, and also you can manage the patient better by taking an account of all the various variable factors that include the psychology, the social life, the whatever factors that lead to aggravating the condition or hinder the treatments, and as chronic disease prevention management, and that include managing cancer and heart disease, but in a more integrative approach. But they don't like to call integrative. They don't like to call regenerative. They don't want to put all those words, because they know they're being kind of red flagged. They just use straightforward chronic disease prevention management. But it's actually everything there. It's the thing that you're doing as a wellness or integrative or regenerative or holistic or whatever. It's just lining it down in under another title, and you just use that title and say, hey, okay, we're okay with that, and do whatever it takes to help the patient.
Hey, Stefan, if I may, real quick, as a Marine, I can say some things that you can't, point blank. And Dr. Hartsfield did a 2-part series on how evidence-based medicine in America has been absolutely compromised. Let's just be absolutely point blank, just boom. And with that being said, you guys are at the forefront of fighting this entire compromised, corrupt system. And Dr. Halassa, I agree with you. We have to work with them. But at the same time, we know what we're working with. And you got to be very careful, because they're very sinister. And they're run by pure money and pure profit. And we know this, for example, especially with cancer. That's why I was mentioning to you, Stefan, earlier with Dr. Hartsfield and Dr. Lewis on the eyes in relationship to dementia and Alzheimer's. That's been going on since the 60s. They put an air bubble in the eye, and it penetrated into the brain. They put oil in the eye, and it penetrated into the brain. So now you got the brain tap, which is using the ears and the eyes to penetrate the mitochondria in the brain. So we've got all these new modalities that are saving our lives. But at the same time, we got 300,000 veterans who just killed themselves since 9/11, okay, based on evidence-based medicine. So I think we got to be very, very, very careful with this whole perception on evidence-based medicine and chronic disease prevention medicine. Okay, you guys are the doctors and the physician assistants and the nurse practitioners and the homeopaths, especially in Nevada, that are fixing people. I'm with Dr. Clearfield, and I got the VA hospital now that are sending veterans to Dr. Clearfield. They're sending employees to Dr. Clearfield, okay, because they know of his reputation. So this is such a dire need, and people like yourselves, we have to fix this. This is not some simple little it's just, I don't know how to emphasize this, okay? thank you for all of what you do, but we really need all of your help. And somehow, and Shellstein, he had it perfect. He's like Dr. Lewis, Dr. Halassa, Dr. Fireshine, Dr. Clearfield. We got to start getting together and get all of us on this main sheet so we all know who is who with the body. And let's start like collectively getting together and attack this from a group of all of us who want to really take on and fix what's going on in America. It's absolutely needed. Just my little rant. Thank you, y'all.
Thank you for that. Can we get back to medical stuff for just a moment? Steve, do you have anything on fenbendazole? Can you give us just a little rundown on that?
Yeah. What part of it?
Yeah, I know it has something to do with animal parasites.
Yeah.
So if you don't have it, in your head, that's fine. We'll look it up.
So it exhibits microtubular depolymerizing activity towards human cancers and possesses a potent anti-tumor effect in vitro and vivo experiments. Let's see. Fenbendazole exerts its anti-tumor effect through the disruption of microtubular dynamics, p53 activation, and the modulation of genes involved in multiple cellular pathways. The treatment also resulted in reduced glucose uptake of cancer cells due to downregulation of GLUT transporters and key glycolytic enzymes. So it seems to work, again, through multiple mechanisms for the treatment of cancer.
I know Dr. Forsyth, who's one of our integrative cancer doctors here in Reno, had given some of that to my father. He had a stage 4 prostate cancer. He had prostate cancers in his lungs, cells in his lungs, and he gave him some of that. And he had to go get it at a feed store. That's where we got it from, and it came like as a paste, and we put it in some bread or something for him to eat. And, he took it for a while, but that's a whole other story. So, that's the only thing I really know about it.
You can get it online. You don't have to get a paste. You go on the Happy Healing, and you can get fenbendazole in capsule form or powder form for human consumption.
Okay. So we have Dr. Ruddy. Thank you so much for being with us. And we have her contact information here. And if you want those who've been on here, I can get you the contacts for all of the participants tonight if you're interested in that. There was a question about insulin potentiated therapy for stage 3 and stage 4 cancer. Either of you use any that at all? I know Dr. Nario's.
I think that's a little bit dangerous.
It's actually Dr. Forsyth's protocol. So he literally takes insulin potentiated their insulin and he injects it into the tumors. And I believe he has a 67% success rate here in Reno, Nevada, with stage 4 cancer. One of the best in America, if not the worst.
Yeah, so what we do with IPT here with Dr. Forsyth is actually we give it through IV therapies, not re-injecting it directly to the tumor. So it's a systemic therapy, and majority of our patients would be stage 3 to 4, who actually went through most of them conventional therapy already and had failed. And we use what we call a genetic test, which is the RGCC test, which actually determines specific chemotherapy drugs that will, eliminate their cancer or kill it. It has a killing rate as it shows on that test. So that's the basis of the chosen chemo drugs to be given in IPT process. But again, yes, the percent of the studies that we have currently is for stage 4s that are given at least 10 years of remission would be around the 50 to 60%. And this is actually has been presented by Dr. Forsyth in various medical conventions and organizations. And as we collect data now, we are actually seeing almost still on that same percent still.
So, including ours, he's been to a couple of our conferences. Dr. Forsyth. It's actually on our website, the AOSRD. If you go to the past conferences, you can find his data there, aosrd.org. Go into the past.
I'm just wondering why up to now the oncologists are not recognizing personalized cancer management, which I think exactly what the doctor just said about genetic testing of the chemo sensitivity of the cancer, and instead of just throwing the same regimen for everybody.
Why do you ask these questions? I mean, today somebody came in and said the gynecologist told him I was crazy for giving the lady who had a hysterectomy progesterone. I mean, why do you ask these questions? Why am I giving the same gynecologist? Why am I giving the woman testosterone? All right, that's all it's going to do is grow hair. I mean, why do you ask these questions? You know the answer.
No, it just more of to emphasize the problem that we have is there's a disconnection between the mainstream medicine and real medicine. Personalized cancer management is not yet in the mainstream medicine. Up to now, they're using the same chemotherapy, the same regimen for everybody, regardless of their genetic sensitivity. And that's where something needs to come up with, at least a new field, instead of calling them oncology, maybe personalized oncology, and recognize the importance of cancer sensitivity for chemotherapy and choose the right drug. And also those testing companies, they're not based in the United States. All of them are in Greece, Germany. We don't have a cancer genetic testing for chemotherapy. That's FD. That's something that here in the United States, as a clinician, can test the sensitivity of cancer. Right? Am I right on that? Somebody knows anybody in U.S. based lab for?
They call the genetic test the Greek test. And so I think so. I think you're right. So
it's either in Germany or Greece, yeah. And we don't have it here in the United States. And that's also some big question mark there. Why?
So
that's a big open question. That's a big open question. I think we all know.
Yeah, there's not enough money in it. There's not enough money in it. or it interferes with the pipeline. Either it disrupts the pipeline or there's not enough money to be made. And so that's it. It's,
So Dr. Forsyth, actually, I don't know if he shared this story. He actually presented his results to our hospital here in Reno, So as he presented this and enticed the hospital and other oncologists to join and then basically integrate this to their protocols. Mm-hmm. The answer that he got from our big facility here is, why would they integrate his protocols when the current facility of oncology in their hospital is the biggest money-making part of the hospital? And if they integrate IPT in there, there goes the income, and there goes the biggest machine that runs that hospital. And then he left. So,
right. So hopefully, the way to bankrupt the what I call the creeps, I just collectively call them the creeps. The way to bankrupt them is to strategize effectively and methodically ivermectin and other similar treatments, whether it's insulin therapy or mebendazole, whatever, for the treatment of cancer. That's how you bankrupt them. Once people know, once they can actually look at data and talk to sufficient people and read case studies and have conversations like this at an open forum in a medical meeting. Once people hear this, they're going to go for it. You're not going to have to convince them. It's an easy choice, I think, for many patients. There are going to be a lot of them that are just going to, oh, I'll just do what my doctor tells me and whatever, fine, go with God. Okay. But there are going to be a lot of people who go, I don't want all of that. Not if I can have this with better results. So that's why this is so important. That's why I compare us to astronauts. This is the frontier, because we can do this. We can give patients, and it's open season now, open hunting season. The tables have been turned. Probably not a good analogy. We can now use ivermectin. Okay, the FDA said in the 5th district on August the 8th, we can use ivermectin based on our judgment. Okay, license to hunt. Now we can do it. Let's do it.
Well,
You
we
know,
can do.
They also
There's
said they
one
never
thing that
told
can
us.
be done.
So
One thing can be done, and that will definitely cause the breakthrough. Is the lab in Germany that is doing cancer chemotherapy sensitivity, which is called like the genetic sensitivity or genomics for cancer sensitivity, and then you can use ivermectin because they can try. They have. I know the lab. I went to those labs in Germany, and I met with the people there, and they can test any drug by taking sample from the cancer of the patients, and then they have certain testing or certain procedure where
Sure.
they can test any drug, including ivermectin, to see if this cancer is sensitive to the ivermectin or not.
It's great.
All it takes is having this lab and this procedure and protocol proved here in the United States and having a lab here in the United States. And the FDA is denying and consider all those genomic testing for chemotherapy invalid, unproven, investigational. And there is nobody wants to invest and do it here in the United States because it seems like they will be harassed or be closed by the FDA. I don't know why, but this is a breakthrough like we did with stem cells and exosomes, which are fighting it. If there is a brave billionaires who can bring this and pass the FDA and start doing the testing here, I mean, we can do a tremendous job in helping patients here instead of sending them to Germany and Mexico. They can be managed here in the United States.
Well, this is the value of a PMA, because by common law, a PMA is exempt from federal and state regulatory agencies. It's a private medical association. It's like a golf club. And so you become a member of the PMA, and then the rules of the PMA then are what is referential for the conduct of it.
You mean the PMA, the national, the Indians tribes? Is that what you're saying?
Well, that's one of them. The body health is another that Avery has started.
Well, I have the group. I have the national people, but the problem with those national Indian thing, they are not recognizing big pharma products, and that's where I have a problem with, because I want to have the Indians American to have access to both the chemotherapy and the regular drug that the big pharma has, and also nutraceutical and herbs that the other side recognize, so that when we do the sensitivity for cancer, chemotherapy or drugs or whatever, it will be for all those drugs, not just for nutraceutical. So if that the group that we have, and I think Dr. Quinn knows those group, we need to tell those national people that they have to have a right to have a full access to any drug that will serve the purpose of treating the cancer, not to limit us. Oh, you cannot use ivermectin because it's a big pharma product, and we cannot protect you if you use anything outside the nutraceutical and herbs. Is that what Dr. Quinn the problem is?
Yeah, well, Dr. Alassa, what the main problem is that the original statutes that came down between the federal government and the tribes back in the 1800s stated that they could use their own medicine based on roots, seeds, bark, plants, anything like that. And the federal government with two things said they will not, A, they will not assist, and B, they will not defend anything that they do. You're on your own, do your own medicine. If things come from plants, I think there's a way that can be done. But as you know, Big Pharma will take something like metformin that originally came from a plant. And back in the 50s, they modified the molecule to turn it into a drug. those things are not going to be covered under the Indian tribes formularies. That's one of the problems. The only way around that is if someone wants to have a collaborative or a separate type of practice, it seems to be okay. And when people say, oh, watch out, you know, you don't get involved with the tribes because they can't protect you. Well, every single one of those persons went against what the tribes stand for, which is their own medicine. If you want to do both, the suggestion is have a separate clinic. If you have a cancer patient that comes in that needs ivermectin, then by all means, send them to your other cancer clinic and get it there. If you want to deal with quote unquote natural or indigenous medicines for the treatment and prophylaxis there, then do that. It's just like anything else. If someone comes into your office, you know, a general practitioner type of office, and they have, oh, my arm hurts. And if they have you think a broken arm, you're going to send them out for an x-ray. You're going to refer them out. Nothing says you cannot own more than one facility. Just don't cross-pollinate those. I want to say one more thing about the ivermectin situation, and Dr. Alasa, you know this as well as anybody does, is that if this does really well and the word gets out, and Big Pharma wants to squash it, they will squash it at the pharmacy end. They will not allow the pharmacies to purchase that. You'll have to find another source. They've done this numerous times with numerous things, and they have no problem in going to the state boards, putting their pressure on them, and having their inspectors come out and rip you if you at all fill any type of prescriptions like that. It's a scary situation.
Well, in California, the drug manufacturers got the state board, the FDA got the state board to essentially scare pharmacists in any of the retail chain stores from dispensing ivermectin for anything other than a documented parasitic infection.
Exactly. They can control that. They'll control the source. They don't need to attack the physicians at all. They don't need to attack the patients. They clamp down on the source, and it's very easy to do.
Yep.
I'm part of a group out of Texas that gets into the PMAs. And right now there's a big, huge court battle nationally with PMAs, big time, because Dr. Paul Salatin, or not doctor, but Paul Salatin, he's like the famous farmer that created this, and he took on the food manufacturers, and they were really pissed off at him. So there's a big, huge PMA thing going on right now, but it's not as shielded as what we think it is. From what I've learned from some of the people that I know, they're shielding their PMAs through their trust. That way you're doing like what I call double jeopardy. You're kind of like protecting yourself through a trust with your PMA, because your private membership association is still controlled, ironically, with the government. It's not like you're that shielded, just not shielded.
Yeah. Oh,
Hey,
exactly.
Can
Exactly, Joel.
Can I
That's
make a
exactly
comment?
it.
Can I
Yes,
make a
please.
comment on that case? So
please.
I actually know the guy who wrote the PMA for that gentleman. And what happened is the attorney that the farmer used
Right.
had the farmer sign a waiver allowing the government to intercede. And so he literally broke the umbrella of the PMA by
Right.
signing that document, and there was no way to go back and change it. So
And
he was just very ill-advised by his attorney, and that's why the PMA was pierced.
And there's another gentleman out of Sacramento, California, that's big in the PMA industry. I don't know if you know of him. I forget his name off the top of my head, but he's trying to fight the same thing. He created a store where he was selling his own organic alcohol, and he got in trouble with, ABC. It's the same type of event. So it's like the big, huge fight with the PMAs and the government, and they know we're taking them on. It's like the body. It's the same thing. We're at the crust. We're at the precipice of taking on big pharma and taking on big. So it's
So
like,
I agree completely that the fastest way to cut us off at the knees is to cut off the supply chain. I mean, this is the principle of war. Okay. If you want to take out an opponent and you didn't think you could
Yes.
beat them fair and square on the battlefield, just get the wagon train. Okay. Just blow up
Yes.
the bridge, blow up the trains. Okay? They don't have ammunition. They can't win the war. They can't even live. Okay. So I totally
Great example. That's
no,
an
but
absolute great
thinking that-
example.
We're thinking that you have to secure the supply chain, but these are early days,
Yes.
right? So I don't think that they will cut off the supply chain before we can get the study done. But that's another reason why I've constructed the study as I have done. I'm not prescribing the ivermectin. The patients are electing to access ivermectin how they want to access it. If they need some help because they don't know where to go, I can send them to the physician who's part of the Indian tribe. Her husband
Can
is
I add-
okay, you get that. So all I'm doing, I'm principal investigator. All I am doing, okay, I'm not providing medical advice. I'm merely collecting the data.
Okay.
And then
Okay.
here's the other thing is that if we just keep these studies going, we never close the study. We can just like Framingham, we never close the study. Framingham just published every 2 years. If all I do, if anybody else does, is keep studies open and ongoing and broaden the studies, we never have to go to the FDA because the studies are still open and enrolling. And they can go to hell.
I've heard about this before. I'm glad you brought that up because then they basically can't exert their control over you.
There's nothing, I'm not doing anything wrong. I'm collecting data.
Yeah, right.
I'm not prescribing. Okay. I'm not giving them medical advice. A very
Okay.
well, very tight PMA situation. Okay. With belt and suspenders. They can get ivermectin now. The FDA attorney has said it. They can get ivermectin however they get it. If they have trouble, I can point them in the right direction. So the warning to other physicians who are just thinking, okay, well, I'm just going to do it is you're going to draw fire. You're going to draw fire sooner or later. And if you don't really understand about cancer, you could get into trouble. And your colleagues are going to think it's because you gave ivermectin, and the patient might think it's because you gave them ivermectin. You don't want that.
Okay, maybe I should. I'd like to ask you and Stefan. Why do I seem to recall that ivermectin came from a natural source?
Yeah, it did. It was found in the dirt.
In the dirt, yeah.
Off a golf course. In the southeast coast of Japan, and it is produced by mushrooms. Isn't that mushrooms are so cool? It was produced by mushrooms as a way for them to protect themselves. Mushrooms are very powerful. They know how to protect themselves.
Oh,
right?
Yeah.
Right? Plants can't move, so they can put up a big.
No, exactly. Yeah.
Right? Yeah.
That's what I always say. Yeah.
It's a mushroom extract. It's a mushroom extract.
So what I can do, this is Dr. Quinn. What I can do is I can talk to Dr. Benzavenia, who is a naturopathic physician and a tribal judge, who we work with, and I can find out his take on putting ivermectin on the tribal formulary.
Find it in the dirt.
And then that way,
find it
the
in the
government
dirt.
Can't touch it.
See if you can find it in the dirt on a reservation.
Well, I'm busy looking around in the dirt for rapamycin.
Okay.
Let's see if we get Dr. Forsyth to chime in on this. He was, I believe, a lieutenant colonel in Vietnam, and he administered half of the ivermectin in Vietnam. Literally.
Wow.
That's how intense he is. Dr. Nario might know this. I don't know, but I'll do my best to get a hold of him and figure out that process.
The Indians will give up gambling. The Indians will sell their casinos if they can pull ivermectin out of the dirt.
Well, let me add something here. I think it's a better strategy. I'm against entertaining one drug, and you really put yourself on the red flag when you start saying ivermectin is everything. it's also medically it's not correct. I think it's better if
I
we.
never said it was everything.
No, I'm just saying. I'm
No,
just saying.
all I'm saying is I just want to look specifically.
I know your
at
I know
that
your
among other
perspective.
things.
I am
Okay,
coming
that's
up
all.
I'm coming up with perspective of the regulatory investigation and the mainstream doctor out there who is looking for a line to pick up things against integrative doctors or so the best option, and instead of coming up with one way, we can say, okay, we can come up with alternative treatment or what we call adjuvant treatments that is based on genetic testing from the lab, the German one or the Greek one or whatever, and just do everything that is being recommended by the lab by sending the sample of the patient to. You can use also circulating cancer from the blood and the stem cells of the blood. We call it the circulating stem cells, and you send it, or you're sending the sample, the biopsy, to that lab, and they can come up with all the drugs, including ivermectin, that is sensitive to that cancer. Doing this, you are not entertaining one drug, you are actually entertaining a cocktail. I think this is, and then the lab itself can sponsor and support the whole study and the whole program if there's any way who can negotiate with those labs, because they're going to make the big bucks there.
Well, I don't really think it's either. I don't think it's either
Right.
or. The principle, no one is as smart as all of us. So if you think that is worthwhile to do the testing and create a cocktail, then do it. Go with God, do it. I'm going to do this one. You do that one. Someone else is going to do another one. Come on, people. Okay, everybody take the bucket and do what they think is good and right.
I just wanna make finding a way where, like, we know that the guy who was after ivermectin, we know the doctor who is entertaining it, and they are, the mainstream medicine, they're taking him out and picking line that he's ivermectin everything, ivermectin. But if we come up with a different strategy, being more smart with the drug sensitivity based on the chemotherapy sensitivity, I think that's more stronger, more convincing, more evidence-based,
Then do it.
more stronger. But it does not mean I'm not stopping your way of doing what you're doing. I'm just saying it would be good if we can collaborate, all of us, on this thing.
I'm sure we will.
Yes.
This conversation is going to keep on going, no question.
Yeah, I'd like to throw out something here too, is that we use the term cancer, which is, we all know, big business and a red flag. I prefer to talk to people about metabolic modification therapy. And from that standpoint, in conjunction with the chronic disease specialty, I think that all of the modalities fit into this to where people won't be saying they're using ivermectin for cancer. No, it's a metabolic modification therapy.
There you go.
Just to give you guys a heads up that we are actually doing that we are testing anything that the patient wants to get tested in their blood test, including ivermectin or any solution that they want, and we will send a sample to Greece as well. So this is actually being done already.
Excellent. Wow, that's so great.
I've been working with the same thing that you have, and I work with the Germans on this field, and it's very entertaining. But the results from the lab, sometimes it's different and a little bit, not accurate. So we just need to find a way to even invest and see for the investors out there to invest in creating a lab that is more reliable than the ones that's coming up from Greece and Germany. Because if I take samples, send it to Germany and Greece, we will see the difference in their recommendations. And I think we need to find a way to verify all those labs who are coming up with one lab that's more reliable, more accurate than both international. Because I know all of those companies.
Well, Dr. Halassa, I can't believe that you said that the Germans are inaccurate. That's just shocking.
No, the Germans not well. What I'm saying is that there is. If you go to the Germans,
Yeah,
the
I'm just kidding.
results is different from the Greeks,
Oh, of course.
right? In
Of
their
course. Well,
sensitivity.
all
So there's
labs,
some.
we know that. You can send a blood sample to Quest and then send one to anybody, and it's all going to come out differently. Standardization in this instance is probably extremely critical.
Right.
Okay. Well, thank you. I have another call that I'm going to have to jump off for, but this has been totally enjoyable. Dr. Clearfield, my hat's off to you and this group.
Thank you, Dr. Quinn, for being here. Thank you, Dr. Ruddy, for being with us, and please join us whenever.
Thank you.
Okay, anybody, anything else? We got a lot of Dr. Ruddy, you rocks on and those types of comments. Someone asked about where they can find articles on ivermectin and cancer. I think you just do a
Yeah, if you go to Google Scholar and you type in ivermectin cancer, you'll be there for the rest of the day.
right.
Yeah, and if you shy from Google Scholar and all that, you can do PubMed Scholar, and they have the same machine. And you can put the cancer ivermectin. You can come up even with the number.
And you can email me. You can email me. I'll send you the file. We have a bunch. We're like 100.
Okay. We can we can always put it up on the website if that's okay with you, or if not.
Yeah, definitely. You know, Dr. Lewis always tells Dr. Hartsfield to land the plane. So I think it's time for Dr. Burgess to land the plane, right?
Maybe. Hey, I'd like to say one thing, just because Dr. Ruddy kind of said it almost in passing, but extremely important, that if we have a continuous study, we have a continuous investigation. That's how the FBI has been covering their ass for the last 2, 3, 4 years. Involved in all kinds of crimes, ugliness, nastiness, but they don't have to answer anything because they say it's a continuous investigation. So I think what you said about that is extremely important for all of us.
Yeah. Good.
Okay. Thanks, Stefan. Thank you. Great as always.
Oh yeah.
Next week we have, I can't even pronounce her last, Amy Pikzarka. I can't pronounce her last name. She's an RN, an LDN, a CCN, an IFNCP. We're going to be hearing about cell science systems testing. So methyl detox profile, cellular nutrition and assays, Alcott testing for food sensitivities, CICA testing for celiac, IBS, Crohn's array, and who to test. So that's next week. The week after that, at the moment, is open if anybody's available. We have September 5th is open, and I'm going to have to twist somebody's arm otherwise. John, you got anything from the medical school?
All's good. Just want to applaud everybody here because nice ideas. Thank you.
And tomorrow night I will be on Dr. Farshian's lecture. I'll be doing part 2 of 4 of my traumatic brain injury series. So
Great.
If you're interested, if you need his link, let me know. We'll get that to you. I think pretty much everybody on here knows where that is. So, okay. With that, any summary or any last words, Dr. Ruddy?
No, thank you for having me. Thank you for having me.
Thank you for being with us. We'd love to add you to our email list. We've been here. October will be 3 years, every Tuesday, except one July 4th, which was on a Tuesday. We've been here for 3 years, and we have quite a body of knowledge. We continue to we plan to continue on. Like I said, anybody, if you have anything you want to present, Dr. Nario, you want to tell us about the Greek test? I think that would actually be kind of interesting. So I'll twist his arm offline. So okay. So again, thank you everybody. Questions, comments, any summary, Stefan?
Summary is try out ivermectin, give us reports on it. Send Dr. Ruddy patients. She's looking for the stage 3, 4s, some severe sickness there, and so she's willing to take those on. That's pretty cool.
Okay, terrific. Okay, any last words, John?
All beautiful. Thank you.
Anybody else? Comments, questions? We have some new names. We have an old friend, Dawn Gallery is with us. She's an old friend from way back. And we have see a couple of new names here. Thank you all for being here. And like I said, I'll be on tomorrow night. If email me, I'll put my email address here if you want the link. If you don't have it, drbill9@gmail.com if you want the link, and I'll be on tomorrow night at 5 Pacific, 8 Eastern on Dr. Farshin's group. So, okay, everybody. I will, as soon as I get this done, I will have this the video on our website and the transcript. And anybody has any comments, questions? One of these days we're going to get together and get a live meeting together, John, right?
Yep.
Like I said, I think we should do it right across the street from the AOA in Orlando. So, okay. All right. Good night, everybody. And thank you all for being here. We had quite a crowd, stayed for pretty much till the end. So we'll talk to you again next week.
Okay. Take care.
Thank you. Good night.
Everybody.